to speak too quickly, and I will try not to use too much scientific or academic language, but that's what I do. So bear with me. Just to pick up on something that Kathy said, I have spent 40 years working with patients, not talking to patients. That's not what I do. I work with patients. They talk to me, I listen, and I interpret that, and I work then with my clinical colleagues, and I help my clinical colleagues to listen to patients as well. So I think it's important to say that every piece of my research over the last 40 years has not just involved patients, but has come from the patient voice. And that's so important for me to communicate this morning, that there are a number of academics who are accused of doing research to patients. That's not what I do. And I'm really careful that whenever I start a new piece of research, if I start working in a new area of research, I always start with listening to what patients tell me is important. And then I build up from there. And I go back to the scientific literature, and I find out what the literature says that's already known, and I work together with new pieces of information, but really listening to people who are living with a condition, whatever it is that I'm examining. So this presentation, I'm going to talk a little bit about, it's a very broad presentation about how do clinicians, dermatologists, other kinds of physicians and clinicians, how do they currently listen to what patients are saying? And that's why I've entitled this presentation Quality of Life, because that's the phrase that's used when we come to make decisions about resource allocation, and when clinicians ask what do we already know about the topic, the phrase that keeps coming up is quality of life. Now, as many of you will be aware, quality of life is a measure, it's a crude measure, but it's a measure of how people live their lives and their health status. And it's something that's incorporated into decision-making about which medicines, which drugs are used, what technologies are used with patients. Okay? So it's important to recognise that quality of life is a recognised term, but it's not specific enough for us to really apply that to, in my view, to individuals that we're working with. It's a broad, a generic term. And these are phrases, generic and specific, that relate very specifically to quality of life. So I'm going to talk a little bit about why we need to measure and use this term quality of life, what are the shortcomings of quality of life, why it's not accurate and specific enough for some purposes. And in particular, I'll illustrate that with a little project that we did 3 or 4 years ago now with patients with psoriasis specifically, because that's the area of dermatology I'm most familiar with, how we took that information, what was already known in the scientific literature, and listened to patient voices and matched the two up to come up with a project and a strategy for working with patients with psoriasis. So just one thing on this slide that's important to say is it was only in the 1970s really that we began to recognise the importance of talking to patients and listening to patients. But now, subsequently, quality of life is at the heart of good medical practice. It always has been for the best doctors, but now it's incorporated into the way that they work. Not just doctors, but nurses too, and other healthcare practitioners, professionals. But more importantly, it's an expectation that doctors will listen to patients now. So why should we listen to patients? Why should we listen to people who are living with the conditions? It's really important that we capture this thing called quality of life, because it allows us to compare two different forms of treatment that might be available for a group of patients, to compare whether one is better, more acceptable, more effective than another. So it's really important. But it also helps us to explain this problem, and it is really a problem for us as patients and us as clinicians, of why some people don't take their medicines as prescribed. Because you can't have an effective medicine that isn't being taken. And we know that nearly a half of people are not taking the medicines, whether those are ointments and creams, whether those are tablets or whether there's injections. Nearly a half of people are not taking them as prescribed. And we need to understand that. It's not that people are difficult or trying to make life difficult for themselves. There are good reasons why people don't take their medicines, and we need to understand it. But also the quality of life measures that we take aid decision-making, policy-making, and that's crucial because it affects you as people living with a range of conditions. But the important thing is to say that it's a broad measure, it's not specific, it's an indicator of whether how people are living with a condition. It's a broad brush measure. It's not specific enough for us to say that you versus you are living your lives in any particular way. So it's broad but not specific enough. Okay, so we know that there are two kinds of quality of life measures. There are those that try and capture what it's like living for people living with skin conditions, okay? And then there are measures that drill down to people living with specific skin conditions. But when we drill down to only looking at atopic dermatitis, only looking at psoriasis, or only looking at alopecia, we lose some of the ability of that measure to compare people across skin conditions or inflammatory conditions. So we need both types of measures. Okay, the types of measures that we have, the gold standard, because there are a number of different paper and pencil tests, questionnaire-based tests, interview-based tests. The gold standard is called the SF. The measure was developed in the United States and it's become incorporated into decision-making. It's called the SF36. There are shortened forms, because that means there are 36 questions. There are shortened forms of 20 questions, and 12. Each time you reduce the number of questions, you reduce the power of the measure to accurately measure impact. So although you don't need to know the details of that, maybe the SF36 is a term that you might have heard in the past. So which approach should we use? Should we go for a generic approach, a broad brush, a blunderbuss approach, a barn door approach is described sometimes, or should we have a more precise approach of measuring? There's no right or wrong answer. In my view, we need both. Okay. Some clinicians will argue that trying to capture quality of life is a fruitless intervention. There's no point. It's too subjective. Okay? And that's something that I struggle with all the time. When a doctor or a clinician is saying it's too subjective, what they're saying is it's not worthwhile listening to the patient voice. And they're wrong. We need subjective, how that impacts on you as an individual, and objective, the things that we can measure easily, like blood pressure, and come up with a number-based value. We need both kinds of measures. Of course, many patients I talk to are very angry when they hear we shouldn't listen to the patient voice, and you should be angry. I'm angry if people don't listen to me. When I go to my doctor or I speak to a health practitioner, if they don't listen to what I'm saying, I stop the conversation and say, you are not listening to me. And I think that's really important for you as patients who are regularly meeting with health care professionals. to take control as much as you can, and I know it's difficult, take control of the conversation and say, do it respectfully, please listen to me, that's not what I'm saying. And if you keep reminding the doctor or the person that you're talking to that I need to be listened to, eventually they'll listen. Okay. So we know that existing research has told us that living with a skin condition, psoriasis, the one I'm more familiar with, impacts on all aspects of life. Relationships, new relationships, existing relationships, work, whether that's in the home or outside of the home, how you feel about yourself as a person, your confidence, your image, your mental image of who you are as a person, all of those things are affected. And that's in addition to the way that you have to apply your medications, the cost, etc., etc. We know that it impacts on all aspects of life. So what we did when we tried to understand the real impact of living with psoriasis, we went to a variety of sources in the literature for information. So we went to what was known in the scientific literature, but we asked psychologists, we asked dermatologists, and of course we asked patients. Tell us, in your words, what you think the impact of living with, in this case, psoriasis is. And then we put all that information together, looked at where the overlap was and where the differences were, because both kinds of data, information, tell us something. Where there's a shared understanding and where there's no understanding was equally important. We wanted to hear from people living with psoriasis what it was like, even if they couldn't express it in words. And that's difficult for some people who are living with a long-term condition. Sometimes they don't want to tell yet another new person what it's like living with that condition. They lose the ability to express it clearly. And so we said, show us what it's like living with psoriasis, whether that's in pictures, in objects that they brought into an interview, in any way that they could express what it was like living with the condition. We said, it's okay, you tell us or show us in any way. And we conducted a study, a postcard study, a blank postcard, just a piece of card, and we asked people to mail to us or to give us a postcard and put something on it that illustrated what it was like living with the condition. So some people used a lot of words, some people used stick figures, some people brought in objects, and that was really important because in that way they felt listened to even if they couldn't express it clearly. This was a study, sorry, you can't see this is too detailed, but this was a study which has now been published in the scientific literature and is well accepted as an example of good practice of listening to patients and using the scientific literature. This is published in the British Journal of Dermatology, which, although it says British, is an international journal, and really helped to shake up the journal and to encourage them to use more qualitative approaches. That's a broad brush approach that we as academics use to say listening to people and using different ways of capturing data and information. So these are the different steps, the different ways in which we accumulated data to develop this patient-reported outcome, PRO, which is a term you will be using and hearing a lot more as part of the GRID project, as part of this new initiative that Christine will talk a bit more about in a minute. But the key phrase on this slide is patients were involved, really involved at every stage of the process, not just consulted at some point in the process, involved in every stage of the process, including setting the research agenda right at the very outset. So what we identified was missing from existing quality of life measures and the best gold standard measure that's used in dermatology is the beliefs, the thoughts that people have about the condition that they're living with and about the treatments that they are offered and that they're taking. And that was really key because some beliefs about the treatment how necessary it is to take the tablets or to use the creams, and how much concern they had about the long-term use of that medicine really seemed to drive whether they did or they didn't take the medicines. But that was entirely missing from existing measures. Nobody had asked patients, what do you believe about the treatment you're taking? So that was really important. We also know, how do you feel about having to apply creams and ointments twice, 3 times a day and change your bed sheets every day because the moisturizers, the treatments are greasy and unpleasant smelling? How do you feel about that? And we asked people, and that was really the first time that they'd really been asked specific questions about the treatment and about what it's like to be asked to leave the hairdressers if the hairdresser finds psoriasis in your scalp and stands back and goes, oh, I can't touch this. How would you feel about that? We asked them, and they told us. And of course, we also asked about lifestyle behaviours. Many people living with long-term conditions are not able to be as active as they'd like to be. So their activity levels are very low. That's a risk for other complications, and it needs to be addressed. That helps people to put on weight because they're not active. Being overweight is a risk factor for worsening the condition that people live with and for other conditions. And we need to address that. We need to help people to stop smoking, to lose weight, to be more active, to reduce their alcohol consumption, to sleep better. All of those things, those lifestyle issues, which a lot of us struggle with, but if you're living with a long-term condition that affects how well you can do those things, those need to be, patients, people need help in changing their behaviour, their lifestyle behaviour. Okay, so this is too busy, but it's an illustration of the complexity of the new measure that we developed. Had each of those elements that I talked about, capturing each of those elements that we now know is important, and not just how the plaque looks on your skin or how the eczema is behaving in any particular way or any other condition that you're living with. Okay, so the key question that we were left with is, how do we now test this new measure with a large enough group of people so that we can say with confidence, this is a valid and a reliable, and those are two specific terms that we use when we develop a new measure, but it's the gold standard test for whether it's a blood pressure machine or whether it's a blood test. Is this valid? Is this reliable? That means, does it measure what we think it measures? That's what validity means. Is it reliable? Does it measure it consistently over time and across groups of people? If we have those two elements of the measure, and we have to test that by putting the data into different computer packages to give us numerical data that we can work with. So when Christine talked about the need to use data, what we're talking about is information that we can defend and say, this is valid, this is reliable. It's been through the tests and we know it's measuring things consistently. So the last stage of our measure is to say, how can we test this with a large enough group of people to claim that it's valid and reliable? And that's where we're up to. And Christine is going to talk a little bit more, and some of the other speakers might talk a bit more about the GRID project and how we hope to develop a measure that really captures what it's like living with the condition that you're living with. So thank you for your attention.
Thank you very much.